Hi all, I'm Dr. Ujjwal and I'm certified trainer for basic life support and advanced cardiac life support from American Heart Association. Today I'm going to talk about bradyarrhythmia. When the pulse goes below 60, we call it as bradycardia. But when the pulse goes below 50 and starts showing some symptoms, it is called as bradyarrhythmia. So let's see what is the bradyarrhythmia protocol. First, when the patient has a pulse below 50, you have to go for checking vitals, then start oxygen, then go for attaching monitor, then take an IV access and start for the treatment protocol. Now first you have to divide this bradyarrhythmia between stable and unstable patient. So first we should know what is stable and what is unstable means. When we called unstable, let's look first at the unstable scenario. Whenever a patient has acutely altered mental status, I am saying acutely altered mental status, that means a patient who is not conscious, alert or well oriented. Any patient who is drowsy, comatose, they are called as altered mental status, but it should be acutely altered mental status. Then second, if any patient has signs of shock, signs of shock means rapid weak pulse, sweating, so signs of shock. Then signs of heart failure, that means patient is breathless or having bilateral clefts, signs of heart failure. Then hypotension, any patient with hypotension is called as unstable patient. And a patient with ischemic chest discomfort, that means he has discomfort in chest but because of ischemia. Okay, so acutely altered mental status, second is signs of shock, signs of heart failure, hypotension, and last is ischemic chest discomfort. I will repeat again, it is acutely altered mental status, signs of shock, signs of heart failure, hypotension and ischemic chest pain. So if any one of these five is present, then we call it as unstable bradycardia, and if not, then the patient is stable. So let's look at the stable patient first. So if the patient is for example, if a patient comes to you with heart rate of 45 per minute, but his blood pressure is normal, he is conscious, well oriented, he is not having any signs of shock or any signs of heart failure, then this patient is called as stable bradycardia, where you have to just monitor and observe this patient. You don't have to do anything, you don't have to go for atropine, because the causes may be like he may be an athletic person or he may be on some beta blocker, so you have to find out the causes and treat accordingly. So monitor and observe is the treatment for the stable bradycardia patient. Now we'll go for the major patient, like who are unstable patients. So if a patient comes to you who is drowsy or who has a low blood pressure and pulse is 45, then this is called as unstable bradycardia patient. So how to deal with this? First and foremost, you have to give the atropine. You have to give the atropine. Atropine, usually the dose is 0.5 mg. You have to give total 6 doses in 3 to 5 minutes interval, so making it up to 3 mg, 6 doses of 0.5 mg. If atropine is ineffective, you have to start preparing the patient for temporary transcutaneous spacing. So this is called as TCP, transcutaneous spacing. So you can pace the patient for effective outcome. If it is not available or if it fails, then go for the dopamine infusion. Injection dopamine, you have to know the dose. It is 2 to 20 mcg per kg per minute, 2 to 20 microgram per kg per minute. And if it is ineffective, then go for the injection epinephrine, that is adrenaline, 2 to 10 mcg per minute. Here there is no kg. So let's see the doses now, no confusion. Atropine should be 0.5 mg. Doses should be repeated every 3 to 5 minutes. Maximum doses will be 3 mg, that is total 6 doses of atropine. If it fails, then go for transcutaneous spacing, that is TCP. If it doesn't work, then go for dopamine infusion. Dopamine dose is 2 to 20 and adrenaline dose is 2 to 10. So if you say dopamine, it is 2 to 20 mcg per kg per minute, while adrenaline or epinephrine dose is 2 to 10 mcg per minute. Here is no kg. Okay, so if you divide this into this pattern, what is the unstable patient means? Means 5 things: acutely altered mental status, signs of shock, signs of heart failure, hypotension, and ischemic chest discomfort. These are the 5 things which make the patient unstable. So any one of these present, we call it as an unstable patient. And about the treatment protocol: atropine, TCP, dopamine, and epinephrine. Atropine 0.5 mg, maximum dose 3 mg, that is 6 every 3 to 5 minutes interval. Second is TCP. Third is dopamine dose is 2 to 20 mcg per kg per minute, while adrenaline or epinephrine dose is 2 to 10 mcg per minute. So let's see the whole protocol. So a patient comes to you with bradyarrhythmia. We call it bradyarrhythmia when the patient's pulse is below 50. Okay, so which are these patients? Usually these patients are of a sinus bradycardia or first degree, second degree, third degree heart block. Okay, so first degree heart block, second degree type 1, second degree type 2, and third degree heart block. So you have, as soon as you deal with this patient, divide the patient into stable or unstable. If the patient has any one of these 5 signs, go for the monitoring and observation. If any one of these 5 signs are there, then go for the treatment like atropine, TCP, dopamine, and epinephrine in the given dosage. So this is all about the dealing with the bradycardia patient. I hope you have understood this. Thank you.